All right, we're going to start almost evening. So good afternoon, good evening, and welcome to this Hamilton Health Sciences special COVID grant round. We're very pleased to have Dr. Peter Gross today updating us on a new advancement in the management of COVID patients. As you know, everyone has been hearing about this in the news, so it's really a great opportunity. So as we all know Peter, you know, is our associate professor working as a head of service for thrombosis at Hamilton Health Sciences and work with the Thrombosis and Atherosclerosis Research Institute. So we appreciate Peter's time today. Just a quick housekeeping, as always, you know, if you have a question, please put it into the Q&A section, and we'll have a good discussion at the end, and we'll answer them. If you need to put a comment or chat about something, put it in the chat section. And if you like at the end to be brought in the conversation, please raise your hand and I'll bring you in if you want to say your question in person. So without further ado, I would ask Peter to start. Thank you.
Thanks, Dr. Zam. All right, so it's exciting to have this opportunity to present this. It's a very different kind of presentation because we're going to talk about a study that isn't published yet, and I'll have to go around some of the stories around that. So the objectives, hopefully at the end, you'll be able to understand what the meaning of the latest news is, to understand which patients these results might apply to, and be confident about what is known and also what is not known to implement this new therapy if you choose to. So on January 22nd, the NIH had a news release, and one of the paragraphs said, in a large clinical trial conducted worldwide, full dose anticoagulation, open bracket blood thinner treatments given to moderately ill patients hospitalized for COVID-19 reduced the requirement of vital organ support, such as the need for ventilation. A trend in possible reduction of mortality was also observed and is being studied, and the news release later on says over 1,000 patients have been analyzed. So what I'm going to do now is switch to a PDF slide set that was released by the trial platform. This was only released last week on the 28th of January. I think it was released because there was a lot of social media discussion about the trial, including information that wasn't in the press release, and so they decided to adjust this. So everything I'm going to show now is at www.attack.org, and you can look at it anytime. All right, so this is a PDF file, so it's not a slide. I hope everyone can see. So what this is Attack Active 4A Remap Cap multi-platform RCT results of an interim analysis. And the one big caveat is these results are pre-publication, not from locked databases, and are not peer-reviewed. So as an introduction, we started thinking about this in late March, early April, where it was noted that thrombosis is a prominent feature in COVID-19. Some reports showing between 5 and 30% of COVID-19 patients developing thrombosis. Both venous and arterial thromboses were reported. And there was also some pathology reports that microthrombosis might be a key mediator of COVID-19 related organ dysfunction, morbidity, and mortality. At the same time, there was a lot of information suggesting in case series suggesting that elevated D-dimer is associated with increased mortality and thrombosis. And the International Society of Thrombosis and Hemostasis recommended measuring D-dimer in hospitalized COVID patients. At the time when the study started, it was unknown how the D-dimer value should or would impact clinical decision-making, intensity of care, or anticoagulation strategies. There was an observational study that was published in I think early May. It hit the news a little earlier, that there was a retrospective cohort in New York City, 2,700 patients. Therapeutic anticoagulation was associated with increased survival, and the longer duration of anticoagulation was associated with lower mortality in mechanically ventilated patients. There was acceptable major bleeding, 3% on a therapeutic dose versus 2% on standard dose. These were just cohorts. There were obviously limitations, survivor bias and confounding by indication. And there were some other smaller studies suggesting similar benefits of anticoagulations as well. So the hypothesis when we started ATTACK was that in hospitalized patients with confirmed COVID-19, therapeutic anticoagulation safely improves clinical outcomes. So this ended up being a very exciting journey. So ATTACK, which is the study that I was involved with initially, headquartered out of by Ryan Zerkansky in Winnipeg, and two investigators in Toronto, Patrick Lawler and Ewan Gallagher, evolved to become this multi-platform RCT. So what a multi-platform RCT is a collaboration between trial platforms. So after a few weeks, REMAP-CAP, a very large international randomized embedded multifactorial adaptive platform trial joined for the relevant arms, and Active 4A, which is the NIH program for COVID-19 therapeutic interventions, joined as well. So what is a multi-platform RCT? So it's a collaboration between three trial platforms in this case. There were three independent international trial platforms. The protocols were harmonized. There was a common primary and key secondary and safety outcomes. There was a common combined prospective superior and futility rules. And the goal was to try and answer this question, a pressing question in COVID-19 management, as effectively and as quickly as possible by enrolling as many places as we could wherever the waves were hitting. So essentially, the multi-platform RCT is a randomized, open-label, adaptive Bayesian trial of adults hospitalized for COVID-19 that have signs and symptoms consistent with COVID-19. For the non-ICU patients, they had to be randomized within 72 hours of admission. In the REMAP-CAP severe state ICU patients, they had to be randomized within 48 hours of ICU admission. The intervention was therapeutic low-liquid heparin or unfractionated heparin. The therapeutic dose was defined as the hospital policy to treat venous thrombotic events, so therapeutic dose anticoagulation. And the control was usual care pharmacological VTE prophylaxis, the usual care defined according to the hospital policy or the prescriber practice. The study drug or control continued for 14 days or until hospital discharge, and in ATTACK or until liberation from supplemental oxygenation for a whole day, whichever occurred first. So the patients were only on drug for 14 days. The primary outcome, which is a World Health Organization approved outcome in sepsis studies, is organ support free days, or OSFDs. You'll see it's abbreviated. It's an ordinal scale combination of in-hospital mortality and organ support free days. So each patient has days free of organ support. So 21 days would be the best, and then less. And mortality is assigned a value of -1, the worst score. And it's a composite measuring clinically relevant morbidity, going to the ICU and requiring ICU interventions, and mortality. Organ support's defined as ICU level of care and receipt of mechanical ventilation, vasopressors, ECMO, or high flow nasal oxygen. The key secondary outcomes were major hemorrhage by ISTH criteria and heparin-induced thrombocytopenia. Key secondary efficacy outcomes were mortality, intubation, major thrombosis, pulmonary embolism, venous thromboembolism, stroke, MI, length of stay in the ICU and in the hospital. So a priori, the multi-platform RCT main analysis population was stratified into essentially three groups: a severe state of critically ill patients who, when they enrolled in the trial, were receiving organ support or ICU level care, or moderate state patients who were hospitalized but not initially requiring ICU therapies of level of care. And the moderate state patients, because there was this question of D-dimer, were prospectively stratified into high D-dimer and low D-dimer. And high D-dimer was defined as 2 times the upper limit of normal D-dimer at that hospital. There were few people enrolled with before the D-dimer was known. The adaptive design requires decision rules for stopping. So the decision rules for superiority were that there had to be a 99% posterior probability of superiority of the primary outcome. So a proportional odds ratio of greater than 1, because you want to be have more organ support free days. And the definition of futility was a less than 5% posterior probability that at least a 20% improvement for the primary outcome would be achieved. So that the proportional odds would be not over 1.2, okay? The decisions were evaluated separately for each stratum of D-dimer and ICU, and stopping triggers enabled any stratum to stop as soon as the results were available, speeding evidence generation. So this is just to go through the 3 platforms and their PIs. So ATTACK, which I was a part of, is funded by CHR LifeArc, a number of other foundations, 4 countries: Canada, the US, Brazil, and Mexico, 58 sites. Active4's NIH, Judy Hockman, Mackie Neal, and Jeff Berger were the PIs. NIH sponsored and then recruited in the US and Spain. REMAP-CAP, Ryan and Ewan are part of REMAP-CAP. They're the domain leads for anticoagulation, and REMAP-CAP has international funding around the world. The ATTACK and Active4 shared SOCAR as their data management center. REMAP-CAP used Spiral in Australia and University of Pittsburgh Medical Center in the US. And the Statistical Analysis Committee was Berry Consultants in Texas for everything. So the news that came out on January 21st for the moderate state and was accepted by all 3 platforms the Data Safety Monitoring Board recommended. Discontinue enrolling patients as a pre-specified superiority stopping boundary has been achieved in both D-dimer strata, and the safety profile supports the benefit of therapeutic anticoagulation in this population. So this is for the moderate state, both D-dimer strata. Earlier in December, the DSMB had recommended, again, accepted by all 3 platforms, that in the severe state, so this is patients in the ICU, defined as admitted to an ICU and receiving organ support, so high flow nasal oxygen, non-invasive or invasive mechanical ventilation, or are requiring vasopressor or an inotrope, they should discontinue enrolling patients as the pre-specified futility stopping boundary for therapeutic anticoagulation had been achieved. So less than a 1.2 fold benefit with confidence. So, and protocolized anticoagulation interventions in critically ill, already randomized patients requiring organ support should stop, but follow-up should continue according to protocol. So late December, stop the severe state. Late January, stop the moderate state. Severe state stop for futility, moderate state stop for benefit. Okay, so these are the interim analysis that we have. So that is so far from this January 28th release. So from now on, I'm just going to stick to the moderate state. So there were a total of 1,772 patients randomized into the moderate state. And the patients that we know the organ support-free days are 1,398 patients. These are the baseline age and sex criteria of the patients in the moderate state. Well distribution, there was no upper age cutoff, more males than females, as is normal in COVID trials. Sorry, the severe state's the bottom, the moderate state's the top. So this is the primary outcome. So in the moderate state, low D-dimer, the proportional odds ratio was 1.57. So the organ support-free days was about 1.6 fold better getting therapeutic anticoagulation than not. And that's the confidence interval. Moderate state, high D-dimer, slightly lower point estimate, 1.53 fold odds ratio. Those missing D-dimer, similar to the ones with D-dimer, and the severe state, you can see the point estimate showing harm as far as organ support-free days, 0.76, excluding unity and reaching futility. So it's a little hard to understand what this means. So this is a sort of a graph that helps understand things in a little bit of a better way. So the top of the pairs of bars is the prophylactic anticoagulation, and the bottom is the therapeutic. Prophylactic, therapeutic, prophylactic, therapeutic. And these are the top 6 lines are the moderate state. The bottom is the severe state. So in the moderate state, high D-dimer. So what blue is organ support-free day of 21 or 22, and that's the most of the people. And so you can see as you move from prophylactic to therapeutic anticoagulation, the number of people who are organ support-free increases, and the number of people in the blue, which is better, increases, and the number of people in the lighter colors, which is in the ICU, goes down, and then number of people who are dead is slightly lower. In the moderate state, the number of people's dead looks numerically lower. So in other words, the low D-dimer moderate state looked like it had more point estimate of mortality benefit than in the high D-dimer moderate state, which is exactly the opposite of what we expected. The other sort of statistics that you can get out of this to try put it in numbers is in the moderate state, high D-dimer, the proportion requiring organ support in the prophylactic dose, 25%, those requiring organ support in the therapeutic dose, 18%. The moderate state, those requiring low D-dimer, those requiring organ support in the prophylactic group, 19%, in the therapeutic group, 13%. And this is the no D-dimer, and here's the severe state. You can see where there's more red in the therapeutic arm than in the prophylactic arm. The overall moderate state combination of organ support is about 23% in the prophylactic arm and 16% in the therapeutic arm. This is very difficult to understand and complex shifting of organ support-free days, but it's just trying to tell you what the numbers mean to your patient, essentially. The mortality, and these are just point estimates at this time because we don't have all the data and there's no statistics. In the moderate state, it was 5.7% in the therapeutic anticoagulation. in the prophylactic anticoagulation, 7.7%. So it's a 2% absolute risk reduction, but we don't know confidence intervals around these yet. In a severe state, you can see the therapeutic anticoagulation was 3 and a bit % more than prophylactic anticoagulation in mortality. Major bleeding is what you would expect if someone's on therapeutic anticoagulation, 1.6% versus 0.9% in the prophylactic arm. In the severe state, 3.7% versus 1.8%. Thrombotic events were reduced by therapeutic anticoagulation in both states. So from 3.2 in the moderate state to 1.9 if you got therapeutic anticoagulation percent, 11.8% in the ICU, usual thromboprophylaxis versus therapeutic 6.7. Again, these don't have confidence intervals yet. So the interim conclusion is that in the moderate state, hospitalized, not on ICU, and not having organ support, therapeutic dose heparin or low-liquid heparin is superior to usual care venous thromboprophylaxis with regard to organ support-free days independent of D-dimer. The positive effect across morbidity and mortality components of the primary endpoint were shown, and the bleeding, major bleeding rate is a little under 2% if you're on therapeutic anticoagulation in this group. In the severe state, therapeutic heparin does not improve organ support-free days to day 21. The probability that therapeutic heparin is inferior or harmful compared to thromboprophylaxis is 98.5%. There's a numeric increase in major bleeding and mortality, but the rate of major bleeding was what's been reported before in critically ill patients on therapeutic anticoagulation, about 3.7%. So a discussion point, and they added this in the slide set. So given the divergent results between the severe state and the moderate state, so in other words, harmful in the severe therapeutic anticoagulation is and helpful in the moderate, how should we manage therapeutic anticoagulation for moderate patients who become critically ill and go to the ICU? So the trial protocol specified that you remained on what you were on if you became critically ill. So if you were on the therapeutic anticoagulation and you were moved from the ward to the ICU and intubated, you stayed on that. And that protocol, the therapeutic anticoagulation, those patients would have been included in that arm. So we don't know whether therapeutic anticoagulation would have had a greater overall benefit in moderate state if it had been stopped when patients became critically ill. We don't know that. Obviously, they're going to try and answer this question. So this is the end of the shared slides that are on that TAC.org website. And I'm going to go back to my presentation to give a little bit of context. Sorry, I can't find my cursor. All right. So I think we have to be very mindful of the inclusion criteria of the study. You had to be COVID positive. They had to be in hospital for COVID, not for other reasons, and not in the ICU or requiring more than high flow oxygen. And I think this is a very important thing. They had to be in hospital for less than 72 hours. So I think this grabbed a certain population of patients. And I think that the generalizability of these results might be lost if this wasn't followed. And they also had to be expected to be in the hospital for 72 hours or more. So they had to be that sick, but not too sick. The next two slides talk about the exclusion criteria, which are published in the methods manuscript, which is in the public domain. So when ATTACK started, there was no mechanical ventilation, but then when we joined, when REMAP CAP joined, that was changed. So if you don't intend to use pharmacological prophylaxis in the patient for some reason, then they were not eligible for the trial. Okay, obviously, if they had active bleeding, they had risk factors for bleeding, such as specifically intracranial surgery or stroke within 3 months, history of intracranial AVM, cerebral aneurysm or mass lesions of the CNS, intracranial malignancy, history of a bleeding diathesis like hemophilia, GI bleeding within 3 months, thrombolysis within 7 days, presence of an epidural or spinal catheter, major surgery within 2 weeks, uncontrolled hypertension with values like that, or other contraindications to therapeutic anticoagulation. They couldn't have a platelet count under 50, an INR over 2, a baseline PTT over 50, hemoglobin under 80, acute or subacute bacterial endocarditis. They couldn't have a history of HIT or sensitivity to heparin or an allergy to heparin. They couldn't be on dual antiplatelets. They were allowed to be on aspirin, but they couldn't be on dual antiplatelets. They couldn't have an independent indication for therapeutic anticoagulation. And in patients whose imminent demise was anticipated and there's no commitment to active intervention, couldn't be included. If there was an anticipated transfer to a non-study site within 72 hours, that also was excluded. And in the US, pregnant patients were excluded. In other countries, they were. I don't know how many patients who were pregnant were enrolled. Enrollment in other trials related to anticoagulation or antiplatelets were excluded, but they could be in other COVID trials. And then obviously refusal of the treating physician. So I think if you want to start using this on your hospitalized COVID patients, you need to be aware that this data is not being peer reviewed. It'll probably be in publication is 3 months is probably the earliest. I would strictly apply the inclusion and exclusion criteria. I don't think a thrombosis consult is needed. The anticoagulation should also be dosed and for the duration in the trial. So in other words, only for 14 days, okay, unless another diagnosis warrants anticoagulation. So if the patient's discharged from hospital, it stops. If they're still in hospital on day 18, you stop on day 14. And if there's any bleeding, the anticoagulation should be held and likely stopped indefinite, and not resumed. The point that the study had about continuing if the patient worsens and is transferred to the ICU, I think should be a discussion. I don't know what the right answer to that is. One more point is that, this evaluated heparin, low-molecular heparin, and the D-dimer result was kind of the opposite of what we thought. So in other words, those people who had the lowest D-dimers did better than those with the highest D-dimers. So in some ways, this suggests that this may not be an anticoagulant effect. So I would shy away from I would not extrapolate this to oral anticoagulants. So I want to thank all the 3 trial platforms. Being part of this group was a wonderful experience. We enrolled people in Hamilton. Dr. Andrew Chung was the St. Joe's co-investigator, and Sam Schulman at Hamilton General was the HHS co-investigator, and the research nurse Michelle Zondag and Ariona Krua helped us recruit patients. And I had a number of conversations with COVID attendings that allowed us to approach their patients and put them in the study. And so this is what you get from that. Thank you. I'll take questions.
Thank you, Peter, for this overview. I think that's very exciting data. If you have any questions, please put them in the Q&A section or in the comments. There are a few. There's a question about is there a difference between low molecular weight heparin and fractionated heparin? Have there been a subset analysis of that?
That is planned. The results are unknown yet. Unknown so far, we don't know. The majority of patients did get low liquid heparin.
I've got lost. Okay, sorry. So there's this comment about what is this really? This results about is really, I know it's a long comment, Peter. Probably be best if you look at it and
Sure.
And give us your insight on these multiple questions, basically.
So I think I don't think there's a lot of evidence supporting that this benefit is from anticoagulation. So I think that's sort of the biggest answer to that question. Heparins have pleiotropic effects. They affect a whole number of things: leukocyte recruitment, inflammation, and I think this study, by sort of asking this D-dimer question, was lucky enough to get this result. I think that that's what its biggest, longest post-COVID interruption will be. Ryan Zarakanski is an ICU hematologist in Winnipeg, and he sort of spearheaded this. And when these results came, Ryan said, I was wrong all the time. I was trying to give heparin to septic patients in the ICU. I should be giving heparin or low liquid heparin to pre-septic patients on the ward. So I think this is what the thinking is. It certainly reduced the raw numbers of venous thrombosis, and those are going to be adjudicated, and we'll get a final number on that. It certainly has an anticoagulant effect, but I don't think the benefit is from the anticoagulant effect. There's a number of pleiotropic effects of heparin that are likely contributing.
Yeah, it's going to be difficult for many of us to really wrap our heads around. You're using anticoagulants, but it's not the anticoagulant effect. There's a comment here around, do you think the benefit from those who are low D-dimer benefited more than the ones with the high D-dimer because thrombosis has already occurred, and those with high D-dimer and it's too late to anticoagulate? Again, back to the same theory. It's all about anticoagulation.
Absolutely, it's possible that that people with a higher D-dimer are in a latter phase or more severe phase of their COVID-19 course, and whatever benefit this is making has less of a benefit. So the point estimates of the low and high D-dimer were the same, only slightly different. You can just see the mortality is where the biggest difference is, but the point estimate of the primary outcome, organ support-free days, was not different. Dr. Kearney has a question about outpatients. So there are a number of outpatient COVID anticoagulation studies that are funded and trying to get going. There's an NIH active 4 study looking at outpatients diagnosed with COVID. Dr. Deb Siegel, who's now in Ottawa, has a study called Virtuoso, which we're trying to get going at HHS, which evaluates outpatients for venous thrombosis. And there are a number of other studies looking at that. Outpatient studies are very difficult to do if you're an academic. What did the protocol dictate if thrombocytopenia developed? So if the platelet count went under 50, the anticoagulation was discontinued. Dr. Dorsami is asking about D-dimer. I don't think that I would, make my decision if you're going to treat someone this way or not based on the D-dimer. It's the moderate state had benefit independent of D-dimer. The benefit was a little bit better in low D-dimer. I don't think that would make me decide who to do it. I think I've answered Dr. Arnold's question. So Dr. Bourguignon, I'm sure I butchered your name. If you were on an anticoagulant for another reason like atrial fibrillation or previous venous thrombosis, you were excluded. If someone was on a DOAC for atrial fibrillation or venous thrombosis, I would keep them on their DOAC for venous thrombosis and atrial fibrillation. I would not switch them. I don't see a reason to. It might be that those people would work, but that's unstudied. Dr. Ainsworth, frequent or so Dr. Ainsworth's question is about higher thromboprophylaxis in ICU patients if people have higher D-dimers. So, the severe strata analysis is very complicated because a lot of the people got prophylactic doses that were very high. So in other words, some parts of some hospitals in Europe will give someone in the ICU equivalent of dalteparin 7500 as prophylaxis. So, that's fine if you weigh 100 kilos like I do, but if you weigh 45 kilos, then that's a pretty close to a therapeutic dose. So there's a little bit of dose per weight issue in those patients. I still don't think we have any evidence to support more than prophylactic doses in the ICU. Why not just a spurious subgroup effect? If one group there's less death than other, there's more death. So this anonymous person is asking this question because these were not subgroups, these were pre-specified strata. So patients were enrolled in, and this was a pre-specified strata, and randomization was done that way. So it's not a subgroup. And even the stopping criteria of the studies were dependent on strata. So in other words, the severe strata was stopped a month before the moderate strata. It's not a subgroup. Dr. Engels, time of initiation of the intervention, we don't know whether if you give it earlier or later, it's better or worse. We don't know that. Dr. Sadia, has age comorbidities been adjusted in the model? We don't know that yet. We just published HIT patients with COVID-19 do not have HIT, but have immune complexes activating platelets in HIT independent manner. In fact, HIT inhibits the platelet activation dose dependent manner. Any of this relevant to the clinical observations? It's a good point, Dr. Nazi, but I don't know the answer to that. The HIT, suspected hits are going to be evaluated by an adjudication, a special HIT adjudication committee, and we'll see. We didn't get enough biosamples to actually ask that question properly. Do we have information about how many patients went from moderate to severe category? Dr. Panju is asking. So, let's see. Let's just look at that sheet again to answer that question, maybe in a better way. So, if you take the two moderate strata with the high and low D-dimers, the ICU is moving away from the dark blue, right? So the best bar you want to be in is the darkest blue, where you had 21 or 22 days of organ support free days. So in other words, this is the absolute benefit. So it's probably around 50, here's the numbers at the bottom. So probably around 12% of people didn't need anything in the therapeutic arm versus the prophylactic arm if they were on more than that would be described as a severe state. So if you enrolled further in here, there would be severe state. I hope that answers your question. Yeah.
So Peter, there's like multiple comments in the chat as well. Repeatedly, the question is like this, that you're getting better effect with the less severe disease. Does that concern you? I know that this we saw this again in remdesivir, effect, which is in a different drug, same disease. It's like, do you think that's because you get to a point that you can't reverse what's happening, or is that a concern about the intervention here?
I think people are overstating the change in the bar graph, because the proportional odds ratio of the change of the organ support free days is 0.04 fold. Okay, it's nothing. I don't think that's the graph slide shows there's a different spread of where these benefits are between the low and high D dimer, but the point estimate is pretty much equal of the primary outcome.
The other thing is about between moderate and severe disease. Like, why would you think the benefit is here only in the moderate disease but not in the severe disease?
The horse has left the barn. I mean, I have no idea, but I mean that's one possible explanation. Okay, in other words, that this is a bunch of thrombosis and hematology doctors doing an ICU study, and we were stupid enough to study people who weren't that sick. And so that may be why we got this result.
Excellent. No, this is fascinating. I think there's absolutely practice changing, and I agree with you. I mean, we should stick with the exclusion criteria strictly for now if we decide to implement that. One question about the type of low molecular weight heparin: is there any difference between, or was there any specific ones in the study, or we could use any available low molecular weight heparin?
Yeah, so it was institutional low molecular weight heparin, whatever your institution uses. They were all of them used. When the final publication comes out, hopefully there'll be a subgroup analysis suggesting that one is different than the other. Maybe it isn't. We don't know that's coming.
Excellent. I think, Peter, you did go through all the questions, and I think we went through the comment. This is really great. I really appreciate you putting this together. It's very important for all of us and for this quick practice change. I think there's a comment from Dr. Workington. As a helpless sick patients who can benefit from therapeutic dose may not be admitted. So thinking about in the change of practice, and if those who usually get admitted are now not admitted and they're staying at home, should we consider treating them at home? I think the big question is use of oxygen. I'm assuming for episode right moderate, they were all using oxygen, right?
Yeah, they had a reason to be in hospital, right? You had to have a reason, and you had to have a reason to be in hospital, and you had to be expected to be in hospital for another 72 hours. So that's how sick you had to be. Okay, so I think if there is a fill up of hospitals and there's people being treated in other places that would otherwise have been in a hospital, as in when the study was done, then that might be reasonable.
Yeah, to that point, I mean, we've been discharging patients earlier and sending them from ED with home oxygen and monitoring at home. So maybe at one point we may, keep at home who are usually at the hospital, and then the same thing may apply. But for now, I think it's great. Well, Peter, again, thank you very much for your time. I think this is very, very helpful, and we appreciate your overview. I think we've covered all the questions and the comments. Appreciate your time, and thank you everyone for attending. Thanks, Peter.
Thanks.